Hi, everyone, and welcome back to Flourish Well. This month, in honor of Endometriosis Awareness Month, I am joined by Dr. Tara Chadwick. Dr. Chadwick is a board-certified gynecologist who specializes in pelvic pain, including chronic conditions such as endometriosis and adenomyosis. She blends her extensive knowledge with incredible kindness and care, and I am so thankful to have her as a resource for my patients. Enjoy the episode. Thank you so much, Dr. Chadwick, for joining us. I'm so glad to have an endo expert here during Endometriosis Awareness Month. So thank you for joining me on Flourish Well.
Thank you so much for having me. This is so exciting.
Of course, yeah. So because it is Endometriosis Awareness Month, like I mentioned, and pelvic pain is a big part of my practice, and that's your area of expertise, I wanted to ask the expert and hear from you kind of what you take people through when you're pursuing a specific diagnosis when it comes to pelvic pain. So thank you so much for being here.
Of course, happy to bring more awareness to endometriosis. It's something that's luckily getting a little bit more attention these days, and our goal is to help people. So things like this, where you can bring what we do to people, is always helpful.
Yeah, love it. Awesome. So diving right in, when someone comes in to see you for a well appointment and mentions they're having pain, what key details do you listen for to reach a good diagnosis?
Yeah, so typically I want to kind of bring it back and get a whole history about their menstrual cycle, because your menstrual cycle is a lot of times an extra vital sign. It can tell us how healthy things are going in general for you. So usually we'll kind of boil down, is the pain with your period, is the pain without your period? Because as you know, pain could be multifactorial. So if they're coming to see me, most of the time the pain is with periods or ovulation. So usually I want to find out, do you have a period every month? If so, if you're skipping periods, we kind of talk about the pattern there. How many days do you bleed? And what is bleeding like? Light, medium, heavy. Because sometimes the interplay between pain and bleeding can help us determine whether or not this is endometriosis or more of an adenomyosis picture, that type of thing. And pain and bleeding are subjective and kind of hard to perceive for different people. So I try to boil it down to something that's a little bit more concrete. So for instance, we'll ask, what's bleeding like? If somebody tells me my bleeding's heavy, I say, okay, what do you use in terms of pads, tampons, that type of thing? And if depending on what you use, how often are you soaking through it? How often do you have to change it? Do you have clots with your period? So that can sometimes give us an idea about what's going on during the period. And then in terms of pain, I want to know, where is your pain mostly? So when you have a period, is it always in one spot or another? Is it diffuse? And then does it radiate anywhere? Do you feel it in your back? Is it mostly just in one side or the other? And then we try to get a grasp of how painful are the periods. So, sometimes people have a really high pain tolerance. So they'll tell you, no, my pain's not bad. And then you kind of get into it and boil it down. And it turns out they do have to miss work days, things like that. So usually I try to say, is it kind of mild to moderate? You can take something like an Advil, you feel better, cramps are gone, you go about your day. Or is it something where the pain medication doesn't help and you're having to miss your daily activities? So you're missing or calling out of school or work, or it's something where you can't do the things you would normally do because of the pain. So that's kind of where we start there. And then with things like endometriosis, there can be a lot of associated symptoms besides just the pain. So I usually will ask people about GI symptoms. So do you have nausea or vomiting during periods? Do you ever have constipation, diarrhea? Do you have painful bowel movements or painful urination with periods? And, kind of from there, it starts to give us a little bit of a picture. We also want to know about pain with intercourse, initial insertion, deep penetration. What does it look like there? Because as you know, that can be kind of different etiologies there. And then once we kind of get to that, then we talk about pain between periods. Are you having pain with ovulation? Do you have pain every single day that doesn't worsen at all with your period? Or is it really just periods, ovulation? Sometimes with more advanced endo, we do see daily pain as well. So kind of just trying to find out how often it happens, where it is, does it have any associated symptoms? And is there anything that makes it better, worse, helps with it?
Yeah, I love that. Because I think, I know I've definitely had some patients that have come into my office and are like, I have endo. And then we talk about it. And I'm like, this doesn't sound quite like endo to me. And that's where I'm like, go talk to Dr. Chadwick because she knows a lot
Yeah.
more about this than I do. Um,
And endo is kind of a strange disease where it's so different and it can present so differently in every patient. So it's something that, unfortunately, we can only really definitively diagnose surgically. So we can never, if somebody has pain with periods, we can't really ever rule it out without that next step. But not everybody needs surgery, which is kind of the good news there. But it is a little bit more difficult. So sometimes people will come in and they've been sent by GI because they've had a whole workup and things are normal there. Or they're just having this pain that they've been on birth control, or they feel like whoever they've been seeing maybe hasn't thought of the whole picture or isn't an endo expert. And it can be definitely very hard to diagnose. So we always kind of go through everything step by step to try to figure out what's going on. And there are times, same thing with us, where we hear a story and I'm like, this sounds, like endo. So we could reasonably suspect. And there are other times when you listen, you say, hey, I don't know if this is going to be endo. Honestly, it's not the classic way that we see it present. Not that everybody presents in the same way, but, usually we're just honest with people. Hey, I think we're going to find endo here, or we may not find much endo, but at least we decide, that gives us some information as well.
Yeah, 100%. And that's really helpful too, because part of my question with this is, it's helpful. I like making sure that my patients have data before they go to see you, right?
Yeah.
And so having those tracking points of like, how many tampons are you using? Are you bleeding through? Are you missing days of school? Like all of that is really helpful information for them to actually have written down instead of like vaguely, we're all bad at our own history oftentimes when we're, in the doctor's office. So that's really helpful information.
Yeah. And sometimes we ask those questions and people are like, well, I never really thought about it, but like, yeah, I guess I do have painful bowel movements. Sometimes I'll try to listen a little bit more to see if it's correlated to my period. So if they get to somebody like you first, who's aware of what's going on and can kind of start making that pain diary, it can be really helpful for us when we see them.
100%. So if you do feel like they're leaning more towards endometriosis or adenomyosis or fibroids, what does the path to surgery look like? And how is it similar person to person? And how can that sometimes change depending on the patient?
Yeah, so those three conditions all can cause a lot of pain with periods, and they're all treated, they kind of have the same categories of treatment, but the surgical management may be slightly different for each one of the different disorders. So usually something like endometriosis, we're going to see a lot of pain, like we said, some GI symptoms, not always heavy bleeding. So that's not usually a major hallmark. Some people do have a little bit of heavier bleeding with endo, but we see a lot more of that like heavy clotty periods with adenomyosis. And people usually will describe sort of the classic pain where it's right in the middle, travels to your back, sometimes down the top of the legs. That'll feel sometimes like contractions. People will tell me, I feel like I have labor every time you have that you have a period. We know that also things like C-sections can increase the risk of adenomyosis. So just kind of getting that whole picture and knowing, okay, you've had 2 C-sections, your pain worsened after your last C-section, it's in those positions, then we kind of know this is probably more of an adeno picture. Although sometimes we do see them run together. So occasionally patients with severe adeno also are associated with endo. So we always kind of keep both of those in the back of our minds there. And then with fibroids, those are really the benign growths of the muscle layer of the uterus. So little benign tumors that form in the uterus. Depending on size, number, location, they can either cause pain with periods, heavy bleeding with periods, or sometimes like bulky symptoms where people will feel pregnant or they lay down and feel like their belly's protruding, or they're just having a hard time losing weight because that uterus is very enlarged there. So with any one of those, we have 3 kind of categories of treatment: observation, medical management, surgery. So observation can include things like low inflammatory diets with your period, exercise before periods can be helpful. Sometimes we will send them to you and do a lot of pelvic floor PT just to try to optimize how they're feeling, from top to bottom. Medical management's usually going to be hormonal modulation. So something like a birth control. Goal there for something like endometriosis is to not stimulate those cells with estrogen. So we want to make periods lighter and less uncomfortable, and try to reduce the estrogen that's stimulating the endo. Endo can also sometimes produce its own estrogen, so we're trying to counterbalance that as well. And then for surgical management, sort of depends which one of those 3 you have, or if you have all 3, which sometimes people do. So surgery generally looks like either fertility sparing, non-fertility sparing. So for something like endometriosis, we can certainly go in laparoscopically, look for endometriosis and remove it. That would be fertility sparing. Non-fertility sparing would be that the uterus comes out as well. Obviously, if we think you have something like adenomyosis where the uterus itself is the source of pain, if we go in and you leave the uterus, you may still have some symptoms there. Sometimes we do that in combination with medical management so that people's periods are a little bit better, even if they have an adenomyosis picture. But then obviously definitive management for especially adenomyosis would be the uterus coming out eventually.
Okay. And can you differentiate for people the difference between adeno and endometriosis? How do they, what is the pathophysiology? Like what's happening in the body?
So for adenomyosis, that's where the endometrial lining, so your uterus has 3 layers to it. You have the endometrial layer, then the muscle layer, and then kind of the skin of the uterus, the thin covering. So sometimes the endometrial layer can infiltrate into the muscle of the uterus. So what that is instead of that uterus just being a good muscle that can contract and push everything out, now that muscle has endometrial tissue, glands, blood, things like that in it. So when it contracts, it has to work really hard to do the same job to expel the tissue and the blood with your period. So that's why it's a lot crampier, because it's just contracting more, working hard. So it does feel like labor pain in that sense. Bleeding's heavier because the muscle gets a little bit stiff. So it doesn't do a good job of clamping down to stop the bleeding. So that's why people have like that clotty, heavy bleeding. With something like endometriosis, what that is where you have those endometrial cells outside of the uterus in the abdomen. So while adenomyosis is all confined to the uterus, endometriosis by definition is outside the uterus. And we know for most people, every month when you have a period, some of that blood's flowing through your tubes and sitting in your belly. And 90% of people clear that away. For 10% of people, we don't always know why. We think there's an immune component and a genetic component. For those 10% of people, those cells stick to the inside of the abdomen and cause pain and bleeding and inflammation. Because they are the same cells in the uterus, that's why they respond to hormones. So every month when you have a period, they get stimulated, you have symptoms. And then depending on where those cells sit, depends on which symptoms you have.
Yeah, and for educational purposes as well, the estrogen is really helpful, or the birth control is really helpful because estrogen forces that lining to grow. And so it's growing wherever it's living, right?
Yeah, exactly. And then the estrogen just stimulates it. So that's why it causes that increased inflammatory response. And then the endometriosis itself actually can release inflammatory hormones when it's stimulated by estrogen. So you get the estrogen and then you get stimulation and then a release of those inflammatory markers.
Yeah, which can increase pain levels and all that kind of fun stuff. Is imaging ever involved in the process before surgery? What does that look like?
For sure. So because there can be different types of things that can cause pain, we always want to make sure we're getting some imaging. So typically we'll start with an ultrasound. That's going to look for ovarian cysts, which is kind of the only way typically on imaging we'll see endometriosis is if you have a cyst of endometriosis on the ovary. Otherwise, we're looking for fibroids, polyps, other things that could cause similar type of symptoms. And then the adenomyosis, which occasionally will show up on an ultrasound. MRI is a little bit more specific for something like adenomyosis. And occasionally, if you have large endometriosis lesions, we'll see that on MRI. So depending on what an ultrasound shows, then sometimes we'll graduate to an MRI before surgery just for planning. And MRI is much better in terms of fibroid management as well.
Interesting. Good to know. Okay, so if somebody ends up having surgery, I oftentimes get a lot of questions in my office, which is funny because I don't prescribe meds. But I get a lot of questions about what does post-operative management look like for somebody with endometriosis? What are some things that you're recommending to them?
Yeah. So typically it's laparoscopic surgery. So incisions are relatively small. Usually you'll have an incision like on or around your belly button, usually one on each hip, kind of down low. And then sometimes a 4th incision or 5th incision, depending on what things look like and who's doing your surgery. Every surgeon has a little bit of a different technique on where they put their ports. And then typically for us, at least you go home the same day, unless obviously you have any issues where you need to stay. But I would say 99% of patients go home the same day. So typically what that looks like is you usually want somebody with you the first day or so, just to make sure if you're groggy from anesthesia that you have some help. For my patients, I usually want you up and moving the next day. The more you can be up and moving, the less risk you have of things like scar tissue forming, blood clots, pneumonias, that type of thing. So really being able to ambulate, being active starting the day after can be really helpful in the recovery process. So that movement is important. Also, sometimes you get some like trapped gas under your diaphragm from surgery that we try to get out, but sometimes it doesn't all come out. And really that movement will help your body absorb that CO2 gas that we use to inflate the abdomen for surgery, and then you'll breathe it off. So really that movement can help with some of that pain too. a little counterintuitive because people are like, oh, when I move a certain way, I feel that under my diaphragm or in my right shoulder. But really moving is one of the best ways to get that to go away. And then, typically we'll give you pain medication. Most of our patients, I would say, use pain meds for the first 3 days or so in terms of something like narcotic pain meds. And then usually it's just mostly Motrin and Tylenol. Sometimes for patients with advanced endo, their pain before surgery is worse than their surgical pain. So sometimes I have patients tell me I actually really used a lot less pain medication after surgery than prior to, which happens sometimes. We do expect that first period to be rather uncomfortable after surgery, just because you have the inflammation of surgery and all of that. So I usually tell people, don't be alarmed if your first surgery is just as bad as prior to surgery. Usually it's going to take a cycle or so for that inflammation to calm down. Not everybody experiences that. Some people will tell me their first period's okay, but usually I say, don't be alarmed. The first 1, maybe 2 cycles may be a little bit more uncomfortable. If you have your uterus in place. Without the uterus, obviously it's hard to time when you would have a cycle, but typically people do a little bit better in terms of cycle pain. And then, if you're up and moving, that also helps your bowels move through, because a lot of times what we see is the worst pain you have after surgery is constipation. So we always, especially from pain meds, it can make you more constipated. So the more you're up and moving, the more your bowel wakes up and also keeps you a little bit more regular. And then obviously we'll use stool softeners or sometimes laxatives to help with that, because that constipation after surgery can sometimes be the worst pain.
100%. And then long term, like if somebody feels like, like a year after surgery, they feel like their symptoms are coming back and that panic kind of sets in. What tools do you have in your toolbox that are helpful for people? Oh, and then also birth control, but we can come back to that.
Well, it kind of is the same, with the tools that we have. So, I think the unfortunate part about endo is that it's a chronic disease and it can always recur. And so we typically see recurrence between 2 to 5 years. Okay. In our practice, we mostly excise endo as opposed to fulguration, which is burning. That's usually to hopefully help reduce the risk of recurrence quite as quickly. If you kind of think about it, the way we think about it is like dandelions in your yard. If you mow the lawn, it looks like the dandelions are gone, but you didn't actually pull the roots. So sometimes when you're just burning the surface, you're not actually getting the entire lesion. So when we excise, we hope that we've removed that lesion so that it takes a longer time for it to return. Also, it gives you pathology. If we remove it and we send it off to the lab, you know where you had endo and that it was endo. So that's kind of the 2 reasons we do that. So we do know it's going to come back. Typically, we use medical management surgery together because obviously our goal is to operate on you as little as we can. We want to make sure that you're pain-free for as long as possible. And obviously multiple surgeries can mean more scar tissue, things like that. So sometimes surgery is the next best option again. Obviously, we hope to push that out at least, as far as we can. Otherwise, usually that's where medical management comes in as well. So usually with the birth control, like we said, it decreases stimulation of endo. But if you think about it from a theoretical aspect, one of the reasons we think endo forms is that you're putting blood into the abdomen through your tubes when you have a period. So the uterus is really that source of bleeding. If we can stop your period or make it lighter using birth control, theoretically, we're putting less opportunity for the endo to seed. So, we oftentimes will use medical management and surgery together as a 2-pronged approach. So if a patient's not on birth control right after surgery, we just kind of monitor symptoms. Sometimes we're doing surgery trying for pregnancy or trying for conception. So birth control is not always an option. If pain starts to come back, then usually we'll think about, is medical management a good choice for you? Is it a good option? And there are lots of different things we have there to help with that. There's also a few medications like an Orlissa, Myfembree, Lupron. Those medications, a little bit like trick your body into menopause, give you some hormones back, but it really kind of shuts down a lot of the stimulation of estrogen. So those are formulated just for pain with endometriosis. Temporary meds, because they can affect bone density. So depending on the dosage, it's either 6 months to 2 years. And some people do have some side effects because you can have some hot flashy type things or sometimes some mood symptoms. Although some people tolerate it really well and it really helps a lot with the pain. So those are kind of the next things that we use. Also, we do a lot of pelvic floor physical therapy. So we send people to see you, because we know that those, as you can probably speak to even more than me, those muscles can sometimes get really inflamed and tight. And when you're in constant pain, that changes your whole physiology. And so oftentimes we'll see that just helping with some of that biofeedback or helping learn how to relax your pelvic muscles can really help with that chronic pain. We also sometimes see people with multiple surgeries, they have so much fibrosis just from where we've taken out the endo that even if we don't see recurrent endo, they're having pain just from that. And we kind of call it like a pelvic contracture almost, because it just is a lot of scar tissue. So even doing like a lot of the work that you all do to help with that scar tissue can sometimes be really helpful.
Yeah, when things are bound down and not moving well, it's not going to feel good. And when the nervous system is sensitized, that's going to make it even harder, right? If that alarm system's constantly going off, we have to teach it that it's safe again, right? Yeah, 100%. I just had a thought about, one of the things that I was told when I received my endo diagnosis by a friend was, you should just get pregnant and that'll take care of it. But that like kind of goes against everything that you're saying, right?
Endo symptoms usually get much better in pregnancy.
Sure.
So just the kind of interplay with how the hormones work, a lot of times people have good resolution of their symptoms, at least temporarily during pregnancy. So,
Yeah.
Sometimes that'll help. Sometimes people will tell you that because if your endo is to a certain point, sometimes it's okay, let's get you as many kids as you want to have. Let's try to get you through fertility and childbearing. And then this uterus comes out because that is considered definitive management for the endo. If you're removing the source, then if we're able to clean up the endo that's there when the uterus comes out, the risk of recurrence is much lower.
Yeah, interesting. That's a helpful perspective because I see, there's so much stuff online, but that's one of the common things, right? Is the discussion surrounding pregnancy. So I think that's helpful information for people to know as well. The $1 million question, why is endo so hard to identify and treat?
I think part of it is that we just don't have a great non-invasive way to find it. That really that definitive diagnosis is surgery. So, and I think for so long, we just, until kind of our field, which is minimally invasive gynecology, really took off as its own separate subspecialty. Before that, we didn't really have the surgical tools to be able to treat it well. So even if you found it, we didn't have a whole lot of providers who were trained in excision surgery or trained in some of the really complex dissection that is needed. Sometimes, we liken endometriosis almost to cancer. Obviously, it's not cancer, but sometimes everything can be stuck together. The scar tissue can be really severe. It affects other organs. So the surgeries can range from very simple, just removing a few spots of endo, to pretty severe where it's, hours long surgery trying to peel the bowel off of the uterus and the ovaries, and it can be really extensive. So I think we've just gotten much better in terms of a surgical technique perspective. So I think now that we have a lot more minimally invasive gynecologists that are trained to deal with it, hopefully that's helping get people to the places where they need to go to be able to take care of it. And I think there's lots of things that go into it. Obviously, a lot of times people will hear periods are supposed to suck, right? And so that's kind of what I get a lot of patients in my office saying, I just thought that this was normal. And then I started, until you're kind of at the point where you're like, wow, I can't go about my daily life. That can't be normal, that you present to care. Or sometimes people will bring it up to their providers and just get, well, let's throw some birth control at it. Or, it's normal to have pain with periods. So while to an extent it can be somewhat normal, it's not normal to really have debilitating pain where it's affecting your life, And I think that some people are well controlled on birth control. So some people we can suspect they have endo and they are well controlled with birth control and they don't ever desire surgery, which is fine, from that perspective. But I think if we had a good imaging modality or a blood test marker, if we had something else where we could say, yeah, maybe you have endo, let's send you for this test and we can know for sure, then it would be helpful. There's some research into a lot more of those types of things. So hopefully it'll be coming down the pipeline and we will have better tools to diagnose it without surgery. But I think that's kind of one of the main reasons. And I think the other reason is, like we said before, it can present so differently in so many different people that unless you're kind of hearing about it every day and kind of able to kind of suss those things out and what may be endo and what may not be, then it's really difficult sometimes to know for sure.
Yeah, 100%. Yeah, wouldn't it be so nice to have like an imaging option, right? Or
Like
a blood test exactly like you said. I mean, that would make things so much easier.
ideally something like a PET scan, if we could find a radio tracker that could adhere to those molecules, and then you do sort of like a PET scan where it says, okay, you're lighting up here, here, and here. That's what, could be endo, obviously would be awesome.
Yeah. Can you also explain why it's important to have a minimally invasive specialist as your treating physician for this condition versus
Yeah.
seeing just like a regular GYN?
Really, so much of endo is recognition, right? From a surgical perspective. And while we all know what the classic powder burn lesion endometriosis looks like little dark, like brown specks, that is easy to identify, right? If you go in and you see that endo, you're like, oh, that's endometriosis. But it can sometimes present in different ways. So sometimes we'll see little vesicular bubbles, which if you're not used to seeing that, you may not think that's endo if you're only used to seeing the powder burn lesions. So those actually are more common in adolescent patients. And those types of vesicular endo have been shown to actually release more of those prostaglandins, which are the inflammatory hormones. So sometimes can actually cause more pain. So if you're not used to seeing that type of endo, oftentimes that's not something that will be identified. So having somebody who's fellowship trained, who's done hundreds of these cases before you get to that, they come to you is really helpful. Sometimes it can also look like white streaks, which sometimes, we'll get patients that they said, well, I had a laparoscopy with my non-endo trained doctor. They didn't find anything. We go back and we're like, oh, it's just because it looked a little bit different than what classic endo looks like. So from that perspective, it's really just being able to, one, recognize it, because if you're not used to seeing the atypical appearance, you may miss it. Also just the technique to excise it and be able to take care of it, especially when it's on things like the ureters, which are the tubes that connect your kidneys to your bladder. It sits there a lot. If you're not used to doing that dissection all the time, that can be a little bit intimidating. You don't want to cause issues. You don't want to make injuries. And if it's down near the rectum or that type of thing, those of us who that's what we do every week, that's a little bit easier to take care of. And we just have the tools in the toolbox and have done this so many times that it's what we do. So sometimes just having somebody who's very comfortable with endo and knows how to recognize it is kind of the most important thing. Sort of the same with delivering a baby. We don't do OB in our practice, but you want the person delivering your baby who delivers hundreds of babies a year. You want the person doing your surgery who does hundreds of surgeries a year.
That makes sense. I remember a case I was talking about with Dr. Gorn, where the previous GYN saw it and left it. And I was like, what?
Yeah.
Like, that's crazy. She goes, no. You want everything to be intact until somebody who knows what they're doing goes in and cleans it out. That's the right decision, which I think, it surprised me. So I imagine it would surprise, anyone who doesn't, isn't in healthcare as well, right?
Yeah, exactly. We definitely see that. Or they'll say, hey, I removed some of it, but the other lesions were in a place where I don't feel comfortable excising it, so I left some. And even, sometimes even with our patients, we'll tell people certain lesions probably should wait until the uterus is coming out. If everything's kind of completely stuck together, sometimes it's really hard to take down a lot of that scar tissue without then removing everything. So occasionally we'll do things as like a staged procedure. We'll get as much endo as we can and say, okay, now it's pregnancy time. And then we'll come in and all of this will come out. All that scar tissue will come down. A portion of the bowel comes out. If we have to do that prior to definitive surgery, we can. But oftentimes, especially the general surgeons we work with who do a lot of those bowel resections, usually like to wait to do that until you're having definitive surgery, just to protect where that bowel comes back together and all of that and prevent it from happening again. Plus, sometimes if your uterus and bowel are stuck together, every time we take that bowel down and the uterus is still sitting there, they just kind of stick right back together. You actually, when you disturb that, sort of like what Dr. Gorn was saying, when you try to excise and you don't remove it all, that can cause actually more scar tissue. So it makes going back in surgically later a little bit harder. So sometimes we know, if a patient comes to me and it's like, I want one more pregnancy, I'm like, okay, let's clear all this out. If it's totally stuck, we should probably wait until you're finished. And then that comes down, uterus comes out. If a portion of the bowel needs to come out, it can, but it can make it much more difficult later to go back in and actually do that if that's been done multiple times, if that makes sense.
Yeah.
The adhesions become kind of thick like cement.
Yeah. Yeah.
The more frustrating thing for us is when people will go in, see endo, not remove it, and then they go back in and do something like a hysterectomy, still don't remove that endo. Because then
Mm-hmm.
for us, we're like, please just send them to us for the hysterectomy so that we
Right.
can take care of all of it at once. Because sometimes if you don't remove the endo, the uterus can come out. But if the endo's still there,
Right. What's the point?
you're still going to have pain.
Yeah. Yeah. Yeah, and I know for those listening, we just glossed over the fact that bowel resection was just dropped, right? I think a lot of people have just in their mind, like endo is like a uterine problem, but you mentioned the ureters, right? Like that's the bladder, that's the kidneys, that's in that related system. The bowel system is involved as well, like you mentioned, but sometimes that does mean that there's major surgery happening around those organal systems as well, right?
Yeah, sometimes we have to shave the endo off the bowel. That's relatively superficial. Usually most gynecologists will do that. Typically, and that's rare, but obviously we see it more in our practice because we are a referral center, but sometimes you can actually get pretty deep, large nodules. Sometimes they grow all the way through the bowel. Most of those patients are going to have rectal bleeding with their periods. So that's something that we always kind of talk about if they have a lot of GI symptoms. And then typically we want them to have a colonoscopy ahead of time, make sure they don't see endo in the bowel. Occasionally we'll get a patient because they had a colonoscopy and the biopsy saw endometriosis. And
Wow.
maybe they never had pain with periods, but it turns out they have endo in their bowel. So they probably have pretty significant endo. That's probably one other thing to mention is that stage of endometriosis and symptoms are not always, they don't always correlate. So some people can have horrible stage 4 endo where, that it's just everywhere. And we go in to operate for something else and we find it by accident. And, they have a fibroid or they have something else going on. Or sometimes appendicitis, they go in and it's actually because you have endometriosis on your appendix. And some people will have horrible endo and never have a painful period.
Isn't that
Very strange.
fascinating?
Fascinating. And sometimes people will be in excruciating severe pain every month. We go in, they have like 2-3 spots of stage 1 endo. We remove it and they feel great. Very weird.
Wild.
So that's, I think, one of the other reasons it's a little bit difficult sometimes to really find.
Yeah.
I say ideally you want stage 1 to 2.
Right.
Enough that we remove it and you feel better, but not enough that it's going to come back right away.
Yeah. This is a completely off the cuff question. So if you don't have an answer, that's totally fine. But is there like a dream, like if you could have 3, groups of researchers doing something somewhere, right, to study, like what would those 3, papers be studying? Like what would those groups be studying?
I mean, I think the main thing would be developing ways to diagnose, quicker diagnosis. So like we said, radio tracker, blood test, something there that can really give us an idea about endo before surgery. Actually, we have a group text with all my partners. We were talking about that today, where there's, some stuff on the market, but it's not really like totally approved yet. Does it actually work well? Who knows? Just trying to stay on the forefront of all of that so that we can help the patients as best we can.
Yeah.
So I think that, and, I think there's the most frustrating thing, I think, as a pelvic pain expert is when there's maybe not endo. And we take care of those types of things. And sometimes we see patients with just chronic pelvic pain. And I think if we have endo, I'm like, cool, we can take care of that. We know how to treat it.
Right.
If sometimes we don't see endo or we remove everything that looks like it could be endo and you have your hysterectomy, you have all of that and the pain is still there. Obviously we know there could be some centralization of pain there. There could be lots of different things. I think occasionally we'll see people with GI motility issues. So they've had a colonoscopy and an EGD and everything looks normal, but they're still having all this pain and it sounds really GI. So finding like we have one at Mercy, but a really good motility specialist who can actually say it's because of how your bowel transits. Sometimes that can cause a lot of pain. But I think the hardest people to treat are the ones where we kind of don't have a great way to treat it or we haven't found the thing that's causing the pain. It's not obvious endo. We've done everything we do there and it's not helping. So, I think just kind of more research into pelvic pain in general, what exactly are those causes that sometimes are hard to identify? Because I think if we could help those patients, that would be great. Our goal is always to make people feel better. And sometimes when you use all your tools and people don't feel better, that's, I think, the hardest part for us is just, what else do we have? So, making sure that we can find those types of things. I don't know if you guys use like those TENS units. Sometimes we have patients that do really well with those types of things. But I think just developing alternatives to like just pain medication that can help a lot.
Yeah, I'm actually debating taking a dry needling of the pelvic floor course, which is like a little crazy. Like it sounds a little nuts, but I've heard it's really effective for a lot of people. And I mean, I use dry needling and stim for other things my patients can attest, and it's oftentimes helpful, especially for things like bladder pain, if they have tailbone pain, like that kind of stuff. After they've had their endo excised, it can make a difference. So. But it's hard. I mean, it's hard on my side. I imagine it's even harder on your side, right? Because there's only so many things that each of us have in our skill set, and chronic pain is just really tough.
Yeah, I think that's the hardest. And you really feel for those patients because it affects everything, your mental health, how productive you can be at work and at home. So, really helping those patients would be what I would hope we could do some research for, because that I think is a subset of people who sometimes get lost in the shuffle. They get lost between specialists. They see urology for maybe interstitial cystitis. They see us for endo. They see GI, and there's not really a thing to pinpoint from any of those perspectives. Or we go in and we take lots of biopsies and there's no endo. So then what is it? And I think that's always the hardest part.
Yeah, 100%. And then finally, what are 3 things you wish people knew about endo or other chronic pelvic pain conditions, just in general? And then if there's like specific things that you wish, your patients knew.
Yeah.
I'd love to hear those too.
I think one misnomer we get a lot of times is where people will come in and say, my periods are irregular, so I'm skipping that type of thing. It must be endo. And for many times, that's not going to be endo. Usually that's going to be a different type of hormonal imbalance, a PCOS type of picture, that type of thing. So we, just making sure that we're kind of educating people about like what to look for endo, because we do see sometimes where people will come in and they're like, actually a PCOS or something like that, where their periods are irregular. I think just knowing that there are lots of endo specialists out there. So if you feel like you're kind of, if maybe your provider does more OB heavy and isn't really always kind of as familiar with seeing endo and catching it, we're always happy to see those patients and consult and and we'll give you an honest assessment. Maybe this is endo, maybe it's not, or that type of thing. So I think just knowing that there are people out there that can help you and don't hesitate to make an appointment, even if it's hey, this sounds like it's more GI. And every once in a while that happens, I'll tell a patient, like, I really think this is GI. And they see GI and they're like, wow, I was just diagnosed with celiac and all my pain's gone. And you're like, excellent,
Yeah.
Right. But just, it never hurts to get another opinion. And, there are lots of minimally invasive experts out there to find. And I think, just educating people in general about endo, it's not something that many people know about. But I think we're finding that there's a lot of celebrities now with endo that are speaking out. So all those things help bring awareness and help bring patients to us who have been suffering for a long time. And, I think the other thing that I want people to know is if you feel like your pain is out of proportion to your friends, your sisters, your relatives, or if you're not able to function when you have your period on a daily basis, obviously everybody's going to have a little bit of like fatigue, some loose stools, that type of thing. But if your periods are really knocking you out where there's not, you're not able to function normally, that's not normal. And you should definitely see somebody about it.
Yeah, I love that. So to summarize for our whole discussion, reviewing like data points, coming in prepared for your appointment, even if it's a well appointment, but maybe call ahead and like let the office know that it's not just a well appointment, right? Yeah. So maybe
I think sometimes maybe that would be a good thing to know too, is that oftentimes provider schedules, and we do, even though we're a surgical practice, we do see women exams and things like that. But sometimes you're allotted a certain amount of time. So if we know it's going to be something where, hey, I'm having a lot of pain I want to talk about, I think sometimes people will feel like I didn't get listened to, but it may just just be that it wasn't the right time or the right venue for that. So if we know that you are coming in to talk about these things, we make sure that you have enough time with your appointment. You're not double booked. Sometimes we may say, hey, we're totally willing to talk about that, but let's move you to a different time slot so that it works and you have as much time as you need. So yeah, that would be the other thing is just sometimes we'll have people just come in for their regular old well woman and like, oh, by the way, laundry list. And you're like, okay, let's try to address all those things plus your well woman. Whereas if we know somebody's coming in for a consultation for painful periods, we can kind of focus and really dive into what's going on. And most of us will take that time during a well woman exam. We're probably going to be late for our next patient, and that's okay. But it would be one of those things where if you can let the front desk know that you have other issues to talk about so that they can make sure you've got the appropriate visit, that can probably be less frustrating for you if you feel like you really want to talk about more than just when's my last pap smear,
when it lets you flex the full strength of the medical system in your medical knowledge, right? Like it lets you help the patient to the best of your ability as well. So, calling ahead to change that appointment type and then coming in with your list of data points. And
most of the time you can actually get a sooner appointment for a consult or a problem than you can for an annual. So that's the other thing. People are like, it took me forever to get in. And I'm like, well, if you tell them it's a problem visit, we have specific spots for that. So we can usually get people in a little bit faster for a problem visit or for a consult for pain than an annual, because the annual is really supposed to be for, you don't really have any problems. So you can schedule out a little bit longer.
General screening, which is also important.
Yes.
Don't skip that. Yes. Don't skip your pap smear.
Yeah.
As much as some people like to try to do that. Okay. So come in with the data points, and then, I lost my train of thought, but being aware that symptoms may be severe, but that doesn't automatically mean that your endometriosis is stage 4, deep infiltrating, super bad and terrible. So do not catastrophize.
Yes. Totally.
So have that perspective, and just keep tracking your data points, because that is still helpful. And if it helps you feel like you're doing something, great, perfect. Find a provider who does minimally invasive gynecological care and who has expertise in endometriosis and adenomyosis and other forms of chronic pelvic pain. And then make sure that you have a good setup for postoperative life, and that may include birth control for you. Because I think that that's another thing that people often come to me with questions about. Girl, I'm not a prescriber. So go in, have that understanding, have an honest conversation with your GYN, because they care about you and want what's best for you. And then, diagnostics are tough. And so surgery is the best option for that. And then talk to people about it. Educate.
Totally. Yeah, exactly.
Love it. Anything I missed? Anything I left out, Dr. Chadwick?
No, I mean, I think the one other plug for medical management and birth control, because sometimes I think people, especially there's a lot of stuff on social media and TikTok about birth control, but I think sometimes we can also use that as a diagnostic tool. So if you start birth control and your symptoms are improved a bit, then it may be endo. Doesn't mean your symptoms are going to be all the way better, but if it's better, then okay, that may be something less GI related that wouldn't necessarily be fixed with birth control. So sometimes we can use those things as a diagnostic way as well. So if your provider suggests starting birth control first, sometimes that's helpful in the diagnostic process. So it doesn't always have to be, because we hear a lot, they just wanted to throw birth control at me. Sometimes that's actually helpful.
Yeah, there you go. And I am so appreciative for you and all of the work that you do and all of the partners at Mercy. And I am so glad that I can entrust my patients to you, because really having a good doctor makes a difference in this world.
Well, we feel the same way about you. We send lots of patients your way because you do such great work and you help so many of our patients. And we don't operate in a bubble. We have a multidisciplinary team, and you're a part of that, and it makes a huge difference for patient care. And
I cannot tell you how much patients appreciate me being able to shoot a text off to be like, hey, I'm not 100% sure about this. What is your thought about this? Because we are a team and our patients get better when we work together. So 100%.
Yeah.
Love it. And people can find you in Hunt Valley, in Lutherville, in downtown Baltimore, and in Towson.
Yes.
And then there's also other partners spread out over the Maryland area. So you can find people online. It's MD Mercy, right?
mdmercy.com. Yep. And we pretty much
Perfect.
circle the Beltway, so you can always find one of us somewhere.
Love it. Well, thank you so much,
Awesome.
Dr. Chadwick,
Yeah,
for
thank you so
chatting
much.
with me. I really appreciate it.
Yeah, it was good to see you. And
Yes.
we'll talk soon.
Yes, we'll talk soon.
Thank you so much for listening to today's episode. Did any of these things sound familiar to you? If so, start documenting your symptoms, call and schedule a problem visit with your doctor, and discuss your symptoms honestly with them. We normalize pelvic pain so much in our society that oftentimes we write off symptoms that may be a sign of something deeper. You can schedule an appointment with Dr. Chadwick by calling the Gynecologic Care Institute at RC. She's available for appointments in Hunt Valley, Lutherville, downtown, and in Towson. Until next time, good strength and flourish well.